All right, welcome back. Today we're doing something a little different, a clinical case lightning round. We've got 9 cases lined up, back to back. I'm going to give you the clues, you make the call. Think you're up for it? Let's see how you do. Okay, the goal here is simple. It's all about pattern recognition. I lay out the presentation, you got to connect those dots. Ready to play? Let's jump right in. First up, Section 1, Clinical Emergencies. Yeah, we're starting with the really high-stakes stuff. These are the kinds of cases where spotting the pattern and acting fast, immediately, can literally save a life or a limb. All right, let's set the scene for case number 1. A trauma patient just rolled in. Gunshot wound to the chest. They are in severe respiratory distress. Their O2 sats are plummeting. And when you look, you can actually see their trachea, their windpipe, is deviated over to the left. You grab your stethoscope, listen to their chest, and on the right side, nothing. Just silence. So what is going on here?
If you were thinking tension pneumothorax, you are absolutely right. Basically, air is getting trapped in that right chest cavity, it's collapsing the lung, and it's physically pushing everything, the heart, the great vessels, over to the other side. Now, here's the crucial part, the real take-home message. You do not wait for a chest x-ray. You act. Step 1 is immediate needle decompression to let all that trapped air his right out. That's followed by a chest tube for more definitive fix. And this brings us to our first huge clinical pearl. A tension pneumo is a clinical diagnosis. You treat first, you image later. Period.
Okay, case 2. A teenager comes into the ER after some kind of eye injury. They are in a ton of pain, and their eye is actually bulging out. We call that proptosis. When you feel the eyelid, it is rock hard to the touch. Their vision, it's going down fast. You do a quick swinging flashlight test, and boom, you see a relative afferent pupillary defect, an RAPD. That means the pupil just isn't constricting to light like it should. This is a big-time ocular emergency. This, my friends, is Orbital Compartment Syndrome. The pressure behind the eye is building up so fast it's choking off the blood supply to the optic nerve. We're talking permanent blindness in a matter of minutes if you don't act. And just like our last case, you do not have time to wait for a CT scan. The treatment has to be immediate, orbital decompression with a lateral canthotomy. So the clinical pearl is a simple equation you have to burn into your brain. Trauma plus proptosis plus a hard orbit plus dropping vision equals orbital compartment syndrome. You have to treat it now. Okay, let's take a breath. We're going to slow the pace down just a little bit and switch gears. Welcome to Section 2, Nerve Investigations. For these next few cases, it's all about playing detective and localizing the lesion. So you've got a patient, they just came out of a long surgery, and they notice something's wrong with their foot. They can't lift it up at the ankle, no dorsiflexion. They also can't turn it outwards, evert it. But here's the kicker. When you ask them to turn their foot inwards for inversion, that movement is perfectly normal and strong. So, which nerve is in trouble? And the diagnosis is a common peroneal nerve injury. What happens is the nerve gets squished right where it wraps around the side of the knee at the fibular neck. This happens a lot from how patients are positioned during surgery. That nerve is what lets you lift your foot up and turn it out. So why is inversion spared? Well, that's the key to the whole thing. A totally different nerve. The tibial nerve handles that movement. This is great because it helps us rule out a much bigger problem higher up, like with the sciatic nerve. So here's your clinical pearl. Foot drop with weak dorsiflexion in eversion, but totally normal inversion. That points you straight to the common peroneal nerve. Okay, let's move from the foot up to the hand for our next puzzle. A patient comes in and says, "Doc, I just can't pinch things tightly between my thumb and my index finger." But when you ask them to make an okay sign, they can make a perfect little circle with those exact same fingers. It's a really subtle clue, but it's super specific. This is a classic ulnar nerve palsy. See, that pinch strength you need comes from a muscle called the adductor pollicis, and that muscle gets its juice from the ulnar nerve. Making that okay sign, though, that relies on the anterior interosseous nerve, the AIN, which is actually a branch of the median nerve. So the clinical pearl here is all about telling these two apart. A weak pinch with a normal okay sign, you're thinking ulnar nerve. An abnormal okay sign, then your suspicion should shift over to the AIN. All right, this next one, you are going to see this all the time. A patient with a long history of diabetes comes in, and their main complaint is this burning, pins and needles feeling in both of their feet. Yep, the diagnosis is painful diabetic peripheral neuropathy. No big surprise there. The really crucial point for this case is all about the management. What do you do for them? The first-line treatment, the place you start, is with a tricyclic antidepressant, or TCA, something like amitriptyline. And that's your clinical pearl. You have to know the treatment algorithm. For painful diabetic neuropathy, you start with a TCA. Sure, things like gabapentin and pregabalin are good alternatives, but amitriptyline is step one.
Okay, ready to keep going? Let's move into our third section, puzzling presentations. These are the cases where the initial picture can be a little, well, misleading, and a really careful differential diagnosis is absolutely key.
Okay, check this out. We've got a 32-week pregnant patient who's having these episodes that her family is calling seizures. But let's look closer at the details, right? Her blood pressure is totally normal. The movements themselves are all over the place, kind of asynchronous and flailing, not the classic tonic-clonic seizure. Her eyes are fluttering, and the moment the episode is over, she's right back to normal. No confusion, no postictal state. Now, anytime you have a pregnant patient with a seizure, you have to be thinking about eclampsia. But does this picture really fit? This whole presentation screams Psychogenic Non-Epileptic Seizures, or PNES. If you look at the comparison, the features are just worlds apart from eclampsia, right? Eclampsia has that crazy high blood pressure and a classic postictal fog. But, and this is a huge but, the stakes are way too high to just guess. You absolutely cannot afford to miss eclampsia. And that leads us to a really important clinical pearl. Even though all the signs are pointing to PNES, you must confirm the diagnosis with a video EEG to definitively rule out a true seizure disorder. Only then can you safely withhold an emergency treatment like magnesium.
Next up, a patient comes in with a painless lump right in front of their ear, in that parotid gland area. But here's the most incredible part of the history. They say it's been slowly, almost unnoticeably growing for the last 12 years. Wow. And when you look, you can see it's actually pushed their earlobe out a bit. That incredibly slow growth, that decade-plus history, that is the textbook story for a pleomorphic adenoma. It's the most common benign tumor of the salivary glands. And that little displaced earlobe, that's a classic hallmark sign. So the clinical pearl here really has two parts. First, the diagnosis itself. A slow-growing, painless parotid mass with earlobe displacement is a pleomorphic adenoma until you can prove it's not. And second, the big red flag. If that same patient came in and had any facial nerve weakness on that side, you have to immediately suspect it's malignant. All right, we're on the home stretch. Let's head into our final section, which is all about cases that really hinge on knowing a specific clinical rule for either diagnosis or management. So here's the situation. A 9-year-old boy is brought in by his parents. They're concerned about hyperactivity and impulsivity. They say it's a real problem at home, although they kind of disagree on just how bad it is. But here's the most important piece of information, or rather the lack of it. We have zero information about how he behaves at school. So the question is, do we have enough to slap on a diagnosis of ADHD?
And the answer is a firm no. Not yet, anyway. This case really highlights a fundamental rule in psychiatry. To make an ADHD diagnosis, the symptoms have to be causing impairment in at least 2 different settings, like at home and at school. Getting a report from just one environment is not enough. So the clinical pearl is also your action plan. An ADHD diagnosis requires symptoms in 2 or more settings. Your next step, always, is to get those teacher rating scales before you even think about starting medication. Okay, last case of the day. You have a patient who suffers from really painful, recurrent gout attacks, and they have tophi. You know, those chalky deposits of uric acid crystals you can see under their skin. It's time to start them on some urate-lowering therapy, like allopurinol. So, look at the slide. I've listed 4 potential reasons to start the drug. I want you to tell me which one of these is not an indication to start the medication.
The correct answer is advanced renal impairment. In fact, it's the total opposite of an indication. Having 2 or more attacks a year, having tophi, or having uric acid kidney stones, those are all slam dunk reasons to start therapy. But having severe kidney disease, that's a reason for caution. And that's our final clinical pearl for today. Urate-lowering therapy is for recurrent gout, tophi, or stones. Advanced renal impairment isn't a reason to start it. It's actually a reason you need to reduce the dose of allopurinol to avoid some pretty serious toxicity. And that's a wrap on our lightning round. You know, from life or death emergencies to these super subtle neurological clues, every single case is its own little puzzle, right? It's a pattern just waiting to be recognized. A huge part of the art of medicine is just seeing those patterns clearly and then acting on them decisively. So the only question left to ask is, what pattern are you going to spot next?